Postoperatively, these patients go to the cardiovascular intensive care unit and are managed by our intensive care doctors along with us and the cardiologist. And it's critical that we monitor a lot of the vital signs, including the pressures within the heart and the ability to use the lungs now that the pulmonary veins are open and unobstructed. And once we do that, it sometimes takes several days to reaccommodate. And once that happens, then we're able to remove the breathing tube, and after another day or two in the ICU, we're able to go on to the ward. And then with our nurse practitioners on the ward, they continue to help these patients get through with ultimately plans for discharge home.
At Boston Children's Hospital, we don't just recommend surgery or cardiac catheterization intervention for pulmonary vein stenosis. We've done a lot of basic science work and even work with our bioengineers to try to understand the problem and how to treat it. So we usually prescribe medications, and not the kind of medications that cardiologists usually use every day, but more the kind of medications that even cancer doctors use that are really targeted at those cells that are growing too quickly. So all of that's the complexity of the treatment for the disease that's allowed us to treat it much better over time. So when patients are on those medications, they need to be followed very closely because these are strong medicines. They have some side effects. You have to watch for that. You have to adjust the dose over time in order to keep the medicines at the best level they should be at. And you also have to watch very, very closely to see if the problem is coming back, because sometimes it comes back very aggressively, even in literally a matter of 4 or 5 weeks. And hopefully over time, the problem slows down, and the cells that are growing too fast, they slow down and they don't grow as quickly. And so then you can start to watch a little less often. We usually, when we're watching very closely, we call it aggressive surveillance. We do echocardiograms and lung scan tests every month when we're worried that the disease is very active. And then when we see it's getting less active, we back off from there.
Well, it's critically important that one addresses all the lesions, in other words, address all the pulmonary vein stenosis involved early on. Because if you leave residual pulmonary vein stenosis, then you're back soon thereafter or have complications from that surgery. So it's really important to address all the pulmonary vein stenosis initially. And if you do that, it portends a better long-term outcome. And despite potentially needing reintervention with a cardiac catheterization later, it tends to be better on the patient in the long term if you can address all the individual pulmonary vein disease.
The biggest problem with pulmonary vein stenosis is untreated, it's really a lethal condition. Over time, those blood vessels just get blocked off completely, and the pressure goes high in the lungs, and that pressure translates to high pressure in the heart, and the heart eventually fails. That's not true in every case, by the way. In some cases, a baby or a child can have a less aggressive form of the disease, maybe in only one vessel, for example, and it can stop on its own. But most of our treatments for patients who have the more aggressive forms are to try to rescue them from that situation and to open up the blood vessels in the veins and to stop the problem from growing back. Our hope is that we can stabilize the disease where the rest of the lung and the rest of the heart is still very healthy. And in that case, patients can do incredibly well and can do many, many normal things. They may, even in the long run, have some limitations in their overall reserve, we call it, how much work they can really do. But there's many things they can do that are, really living a normal life.